Hello, everyone. I am Udhayvir Grewal. I am a GI and neuroendocrine medical oncologist here at the Winship Cancer Institute of Emory University in Atlanta, Georgia. And I will be talking about navigating and understanding of neuroendocrine cancer. What should I know about my cancer? I'm really passionate about, helping patients navigate their cancer diagnosis, especially when you have a diagnosis of a cancer like neuroendocrine neoplasms or neuroendocrine tumor, something that's not often talked about. I think it's really important for you to understand some of the nuances that are critical to establishing a correct diagnosis. Before we dive into the details of the various categories that entail a diagnosis of neuroendocrine tumors, there are some core concepts that I think are really, really important for patients and caregivers to be familiar with. The most important concept is grade. And why this is really important, especially in neuroendocrine tumors, is the emphasis on grade is a lot more than some of the other more common cancers, where stage is the most important factor that is taken into consideration. So when your cancer diagnosis is first established through a biopsy specimen, our pathology colleagues, they look at it under the microscope, and what they're looking for is a proliferation index called Ki67. And what does that Ki67 really tell you is how quickly or how slowly cancer cells are proliferating when looked at under the microscope. So the higher the Ki67, the more quickly those cancer cells are proliferating. And similarly, the lower the Ki67, the more slowly those cancer cells are proliferating. So Ki67 is really important for establishing the grade of a neuroendocrine tumor. Similarly, you might hear terms like mitotic index, which are pretty similar to Ki67, and again tell you how quickly or how slowly cancer cells are proliferating when looked at under the microscope. Another core concept is differentiation. So, like I said, when you first get a biopsy, the tissue specimen is looked at under the microscope by a pathologist. And one of the other things that they're looking for is how are these cancer cells in the tumor tissue organized? If they're well organized, they're nicely put together, they form some shapes, some patterns, these are well differentiated tumors or neuroendocrine tumors. And these are also, as you would expect, better behaving. If what they see is just pure chaos, these cells are different sizes and shapes, and they don't really form an organized pattern, those are poorly differentiated neuroendocrine carcinomas. And as you would expect, these are more likely to be aggressive tumors or aggressive cancers. So the differentiation really tells you how organized or disorganized a cancer looks like under the microscope, which again gives you more information on how the behavior of this cancer will be in the clinical practice. Stage is a concept that is relatively easier for patients and caregivers to understand because how commonly this is talked about. Stage basically tells you how far a cancer has spread compared to where it originally came from. To give you an example, if there is a pancreatic neuroendocrine tumor, of course, that originated in the pancreas, if it is just limited to the pancreas, it would be stage 1 or stage 2. If the cancer has spread to lymph nodes around the pancreas, it might become stage 3. But if this cancer leaves the pancreas and goes to a faraway location, say the liver, that means the cancer is now stage 4. So basically, stage really tells you how far has a cancer spread compared to where it originally came from. And in many cases, the stage and grade, they need to be looked at together. They cannot be looked at in isolation because when we're looking at the prognosis, stage really does not tell you all of the information. It's really the grade and the stage put together that give you the accurate information that you need for getting an estimate of the prognosis associated with your neuroendocrine tumor diagnosis. After a diagnosis is made by a pathologist from a biopsy specimen, the next thing is to look at scans. And this is really important when we talk about stage. The type of scans that you get will make a huge difference in how much cancer are you able to see or appreciate on the scans. So CT scans are commonly done, MRIs are commonly done, but what I really try to emphasize in my practice is that patients should understand that not all CT scans are the same and not all MRIs are the same, especially in the setting of neuroendocrine tumors. CT scans, if they're done with a special contrast and the way the contrast is timed, that can make a world of a difference in how much cancer we're able to see or appreciate on the scans. To give you an example of the liver, this is a common site where the cancer likes to go, especially if it comes from the small bowel or pancreas. The CT scan is done with a contrast, but all we're looking at is how the contrast spreads through the veins and not really the arteries. There's a lot of cancer that we will not be able to appreciate. Now, take a look at these CT scan images on the left. In the image that is labeled as B, we see a liver that really just shows mostly normal tissue because all we have looked at is how the contrast is flowing through the veins. But if you do something called arterial phase imaging, where you actually look at how the contrast was flowing through the arteries, you can see these big bright spot in the liver that is all cancer. So how that contrast is timed and then the images that are generated based on the timing of that contrast makes a huge difference on how much cancer we're able to see or appreciate on the scans. Similarly, when an MRI is done, compared to a CT scan that has just looked at how the contrast is flowing through the veins, you get an MRI with a specialized dye called EOVIST, which I highly recommend getting for most of my patients. This lights up the background liver in a manner that allows us to appreciate the cancer spots much better. So this is a much more sensitive and accurate way of getting an estimate of how much cancer there is in the liver. So basically, the type of scans that you get are so critical in analyzing the actual extent and burden of the cancer, especially in organs such as the liver. Similarly, we have specialized PET scans. I'm sure most of you are familiar with scans such as gallium-68 dotatate or DOTATOC PET scan or copper-64 dotatate PET scans. And these have perhaps been the greatest advance as far as imaging in patients with neuroendocrine tumors is concerned. And these are the most sensitive and specific scans in terms of being able to determine the exact burden or where all the cancer has spread in the body, especially when it comes to neuroendocrine tumors love to go to the bones. CT scans and MRIs can really not as sensitively detect the spread of the cancer to the bones. And PET scans really are the best type of scan that you can get to make sure the cancer really has not spread to the bones. And in patients where I know the cancer has spread to the bones, I like to get this every so often just to make sure I'm keeping a close eye on how the cancer in the bones is really doing. So these scans serve not only a great purpose in complementing what we're seeing on the CT scans and MRIs and helping us get an accurate assessment of the spread of the cancer, they also help us identify patients who may benefit from specialized therapies that target receptors that enable us to get images on these scans. And those specialized receptors are somatostatin receptors. So patients that have cancer spots that light up on these PET scans are also ideal candidates for somatostatin analogs like octreotide or lanreotide and a targeted radiation therapy called peptide receptor radionuclide therapy or PRRT. Based on what we've understood so far, some of these core concepts such as grade and stage and differentiation, I want to highlight some of these categories that are used to put tumors into specific boxes so as to label them with a diagnosis. So tumors that come from the stomach or the small intestine or the pancreas, they're often classified based on the differentiation. Are they well differentiated or poorly differentiated? If they're well differentiated, they're called NETs or neuroendocrine tumors. If they're poorly differentiated, they're called neuroendocrine carcinomas. Within well differentiated neuroendocrine tumors, we look at the Ki-67 to then club these tumors into low grade, intermediate grade, or high grade. Low grade is Ki-67 index less than 3%, 3 to 20% is intermediate or grade 2, and anything above 20% is grade 3. Poorly differentiated neuroendocrine carcinomas are all grade 3 by definition because their Ki-67 tends to be very high, typically higher than 55%. And within neuroendocrine carcinomas or poorly differentiated neuroendocrine carcinomas, we typically have categories such as small cell or large cell type based on the appearance of these cancers under the microscope. Tumors originating from the lung and thymus are categorized slightly differently compared to tumors that come from the stomach or the small intestine or pancreas. We still look at the differentiation. Are they well differentiated tumors are further categorized based on did we see a lot of tissue damage, something we refer to as necrosis, and was the mitotic index higher or lower? So basically, we're trying to see how quickly or slowly these tumors are proliferating under the microscope. Was there a lot of tissue damage that we saw? And based on that, we categorize them as grade 1 or typical carcinoid, grade 2 or atypical carcinoid. And if these cancers are just haphazard, poorly differentiated, they're termed as neuroendocrine carcinomas of the lung or thymus, which again, like we previously talked about, the stomach, small intestine, and pancreas cancers, these poorly differentiated neuroendocrine carcinomas can be further classified as large cell or small cell based on the appearance of these cancers under the microscope. An important thing to understand, and something that is being increasingly appreciated now, is looking at the differentiation, the Ki67 mitotic count. These are just stepping stones to establishing a diagnosis, but they just don't tell you the full story. And the missing piece of this puzzle is adding molecular data or adding genetic information about your tumor that will give you information that is unique to the type of tumor that you carry. And my hope is that in the future, our classification systems will be revised to add some of these molecular or genetic information into the classification system. So we will be able to appreciate each tumor in a more individualized and personalized manner. To facilitate that, at least in my practice, I try to sequence almost all of my patients with a neuroendocrine neoplasm diagnosis, be it well differentiated or poorly differentiated. And the way we get it done is when the biopsy is done, we have a tissue specimen and I send it for something called NGS testing, or this is next generation sequencing. Basically, there are specialized tests that are run to look at some of the DNA and RNA changes in the tumor to see what kind of alterations are there. Are there some alterations that are usually seen in high-grade tumors, and you know for sure if the tumor has those alterations, then the biology is going to be more aggressive, the behavior is going to be more aggressive. Sometimes we may be lucky enough to find something that can actually be targeted with therapies that are either FDA approved or available on clinical trials. So there's a lot of information that you can get from molecular profiling. And what we can do with the tissue specimen is sometimes limited by what part of the tumor was captured. And so we are not able to appreciate all the genetic mutations or DNA, RNA mutations that are present in other areas of the tumor. So the way we can circumvent that issue is by getting blood-based testing, where we sample the tumor cells that are circulating in your blood and running the same tests that we ran on the tissue on these tumor cells to capture some of these mutations that we may have missed in the tissue-based testing. So when we combine the information from the tissue-based test and the blood-based test, that really gives you a full overview, a comprehensive understanding of what are the unique mutations or alterations that your cancer carries. And that gives us a lot of information about what to expect in the clinic and what to expect when we're looking at responses to different therapies. And in some patients, that may even open doors for personalized therapies because their cancer carries mutations that can be targeted with specialized therapies, either the ones that are FDA approved or yet other therapies that are available in clinical trials. Then an important question to ask is, after we've established what kind of neuroendocrine tumor or neoplasm you have based on the grade, differentiation, and stage, the next big question is, does your tumor make hormones? The most common hormone that is overproduced or hypersecreted by neuroendocrine tumors, especially small bowel neuroendocrine tumors, is serotonin. That can lead to something called carcinoid syndrome, and you may have symptoms like diarrhea, flushing, wheezing, and complications in the heart, something we refer to as carcinoid heart disease, where part of the heart valves can become fibrotic or scarred because of exposure to these hormones. Yet other patients may have other hormones that are abnormally produced that may lead to a host of different clinical symptoms and complications. So testing, or at least discussing with your doctor about the need for testing for these hormones, can be very critical, especially in the relevant clinical setting. Finally, I want to highlight the journey starts at the diagnosis, and especially making the right and accurate diagnosis is so critical and paramount What is really critical right from the start of establishing a diagnosis to getting you on the path to the right treatments or selecting the right treatments is the involvement of a specialized multidisciplinary team. Sometimes oncologists that are closer to where you live may have more general focus and may not have a specific focus on neuroendocrine tumors. I think it's really important for you to discuss with them the need for a referral to a specialized multidisciplinary team where there's a host of different specialties like medical oncology, surgical oncology, interventional radiology or radiology, nuclear medicine, pathology. Along with these specialists, there are like nurses, registered dietitians, pharmacists, clinical trials teams, geneticists, all of these specialists that are focused on the care of patients with neuroendocrine tumors or neuroendocrine neoplasms. It's really important for you to get in touch with this team. And if you haven't already seen them, maybe discussing a referral to be seen by a multidisciplinary team, because these treatment decisions are so nuanced. And right from the time of establishing a correct diagnosis to then maybe exploring either currently approved therapies or clinical trials, at every step of the way, you really need input from multiple doctors to make sure we're making the absolute right choice and have the absolute right decisions that are personalized to the type of cancer that you have. And it's important for you to remember that neuroendocrine tumors are not one cancer. Every tumor is different. And the decisions that we make or recommendations that we make in terms of the right treatment plan should be personalized to you and the specific type of neuroendocrine tumor that you carry. So I can't really overstate the importance of getting a specialized multidisciplinary team involved in the care of your neuroendocrine tumor. And lastly, I want to highlight that we really cannot take good care of you without our patient advocates and our patient support groups. Even though I spend a lot of time educating my patients, especially their first clinic visit or subsequent clinic visits where we're making decisions about next line of therapy and so on, even though I do my best to spend as much time as possible, I still spend a limited amount of time with my patients. And it's kind of impossible for me to discuss every little detail or nuance that is going to be relevant to the care of my patients in that short span of time. So I really rely on our fantastic patient advocates, especially at Neuroendocrine Cancer Foundation and patient support groups to really help patients navigate right from their diagnosis for their treatment selection, getting on to clinical trials. I thank our patient advocates and patient support groups for the incredible work that they do. And I advise all of my patients to get in touch with organizations such as NCF to make sure that every step of the way they get all of the right guidance and support that they need. Thank you very much.